there was a very strong sense that scale and systemness made a difference in the pandemic, and that our large health systems were actually essential infrastructure and perhaps the only adult supervision for dealing with the pandemic. And I think we both came to that conclusion, even though we had sort of varying degrees of enthusiasm for consolidation per se. But I do think that we were in sort of unanimity around this whole question of, you know, scale and systemness made a difference. Is that the guts of it, Jeff?
Yeah, I mean, I think this has not been a shining moment for America's public infrastructure in dealing with this pandemic. We're going to lose easily 600,000 lives to this thing. And you know, when I think people do a kind of an autopsy on our society's response, one of the only pieces of our societal infrastructure that really functioned effectively during this pandemic were the multi-hospital systems. And I watched a lot of communities, particularly back here in the East, where systems that hadn't even talked to one another in 5 or 10 years got together and worked together to try and mobilize their resources across a region to try and help respond both to testing and then to vaccination, as well as to the flood of people that needed care. It was a remarkable performance, and I think it was a proof of concept in crisis for the idea that systems can achieve social objectives in a meaningful way.
I always felt, on balance, you'd rather have a coordinated system than an uncoordinated system. You'd rather have an integrated system than a disintegrated system, particularly at the local level. But I think it is fair that you know, one of the benefits that comes with that consolidation is market power, and you've got to be very careful making sure that that's handled responsibly.
What the COVID pandemic did was it brought the community and its needs into high relief, and it focused management's attention on how do we save lives and how do we keep our caregivers safe and functional in this crisis so they can do what they have trained to do. And I think that was the part that I just found so impressive, and frankly, a story that hasn't gotten a lot of ink.
I don't think we've really done a good job of providing a kind of balanced scorecard of how to think about the contribution of systems. During the pandemic, we saw unbelievable responses where they went beyond, you know, their core mission to really provide both the adult supervision, to provide the education, to provide the public health infrastructure that, you know, unfortunately many of our states have underinvested in that infrastructure over time, and it was health systems that really stood out as the big contributors.
The public policy debate is focused a lot on what the rules ought to be for competition in the public interest and in patients' interests. And I guess the position we took in our paper was scale itself isn't inherently bad. It's how the entities at scale behave that matters. And where that gets me as a public policy premise is the discussion about scale and about consolidation ought to be about rules. It oughtn't to presume that scale is bad or inherently threatening. There ought to be a rules-based conversation about what appropriate conduct is and how the public benefits. And once those rules are in place, they ought to apply to everybody in a marketplace, not just the people that want to form a new enterprise. Right. They ought to apply across the board to everyone.
Right. I think this is key, that to be fair, it's got to be consistent, and it's got to be more than just one metric, and it's got to reflect potential contribution, you know, to communities. And this notion of having more than one metric of performance, I think is key. The other thing we shouldn't forget here is the amazing kind of agility and responsiveness that these health systems pulled off, that was very difficult to emulate if you didn't have the scale and multi-hospital capacity.
there are huge disparities in health coverage and in health status in communities that expose safety net institutions to extraordinary economic stress because the people in those communities either don't have health insurance or they have health insurance that pays 70 or 80% of the cost of actually caring for them. The ability to spread that economic risk across a wide geographic area and average it out with payments to more fortunate communities and individuals is something that systems can do. And they can keep vital organizations that would otherwise have closed afloat because of that averaging. So I think that's a very important and unquantified public benefit.
Yeah, I talked to a system yesterday in the Midwest who are operating in Wisconsin and Illinois and have, affiliations and ownership positions with critical access hospitals. Those hospitals would not be in the phone book were it not for the multi-hospital system framework that they belong to. And I think, in our piece, we pointed to the special case of rural and made an argument that we would be supportive of our friend Harold Miller's proposition that rural is a special case and that you need to provide some kind of core funding for a base with a variable funding on a fee-for-service basis and encourage affiliations with larger systems contractually for referrals and so forth to ensure seamless access to care. And I think part of the problem here is that the economists of the world, the pure economists, keep wanting to bring us down to sort of some kind of atomistic health system where you've got lots of buyers and lots of purchasers, all only communicating through price. But that's not the way the world works. And what we patients are looking for is organized systems of care that can look after us when we're sick and can respond to things like a pandemic. The one thing about rural is that there's a sort of essentiality. And so often you'll see in the numbers that rural hospitals can, because the payers up the food chain have to have them in, have got a premium on their commercial pricing. That is not true in a competitive managed care market, with higher population. And so you can often end up with independent institutions being vulnerable. And were it not for the opportunity for affiliation, they probably won't make it and won't stay in the phone book.
I mean, I began my career in this field more than 40 years ago in one of those in an urban academic health center on the south side of Chicago. And one of the things that we learned quickly was that we had to foster and build relationships with those vulnerable, small inner city institutions that were otherwise going to fail. We had to advocate for them politically. We had to fight battles for them with the state Medicaid agency. We had to make sure that we could help them recruit young physicians and nurses to keep their medical staffs viable. There were all sorts of things that we could do with relationships that frankly weren't happening. And what systems have enabled people to do is to do that at scale and deliberately rather than ad hoc the way we were forced to do.
A third of Californians are on Medi-Cal, and our payment rates in our state are not nearly as high as they are in places like New York or Massachusetts. My back of the envelope calculation is if you were going to run an all Medicaid, Medi-Cal hospital as a payer in California, you'd probably have to double the rates to make them viable. And so, it isn't surprising that those communities that have lower socioeconomic status and quote unquote worse payer mix are the very vulnerable ones in the state. And who is going to look out for them? I mean, we're blessed at MLK to have supplementary funding as a special case, but if, the predicament that a hospital in a lower socioeconomic status region has in a metro area, it's just tougher to make it go, given where we are with our Medi-Cal funding rates.
we shouldn't assume that there's something inherently bad about any organizations deciding to come together and work together. The real question is, it ought to be a rules-based system. What are the rules? That's the conversation we ought to be having. I'm not comforted at all by the idea that a legislature or a state official simply exerts administrative authority over combinations and that's going to solve the problem. The real issue is, what are relationships and what are business practices that are abusive to patients and that unnecessarily raise their costs? Let's talk about what those things are and figure out how to make sure they don't happen. I don't think simply extending arbitrary administrative or political authority over new relationships is going to get that job done.
Right. No, I agree with that, and I think it's comes back to what Jeff said earlier about the importance of your behavior, not just scale per se. The other thing is, I mean, we've spent our careers in boardrooms of hospital systems, over the last 40 years, and if you think about the conversations that are going on right now, I mean, then the people are talking about partnership, whether it be with Walmart or Amazon on the one hand, or local physicians in their community on the other. But we believe in organized, integrated systems of care that behave appropriately in service of their community, and that's what the goal should be, not to prevent them from innovating organizationally and building capacity for their local community.
The idea that scale and systems are inherently bad or threatening as a public policy premise is something that we really need to think about. I don't believe that. I think that it's how systems behave and what they intend to do that makes a difference. And that's what we really ought to be focusing our attention on, not
Right.
the arrangements themselves, but what we want them to do.
No, that's well said. I think the other point I would make is, what is the problem we're trying to solve for here? Because we've built systems over time, because we've had the competitive threat and the model of Kaiser, California actually has relatively lower healthcare costs, per capita and premium per capita compared to many other parts of the country, despite the fact that we are an astonishingly expensive state for the raw materials of real estate and humans. Again, I come back to a more clear-eyed view of what is the problem we're trying to solve here, and also how do we judge the behavior of these systems rather than throwing the baby out with the bathwater and saying you can't innovate organizationally ever again, you can't add capacity, and then hope that it's all going to work out just because there's less economic leverage perhaps in certain parts of the state. I don't think it ends well, and it may end up artificially slowing down the rate of innovation in the health system.
There's no way on earth that the revenues in these institutions are going to grow at the rate of the inherent costs of care. And that unless they're able to make orders of magnitude more efficient use of their resources and people using modern information technology to do it, they're not going to be viable. So what type of organization do you need to intelligently and continuously redesign care so that it fits within that envelope of resources that is not going to grow at the rate of inflation?
And at the same time, you've got these pressures, within the physician community to affiliate and combine in different ways. And the other key thing is there is a mega trend of shift to the ambulatory environment, and this is where I think many folk are sort of missing the boat. That health system, most of the large health systems we work with, probably a majority of the revenues now are coming from the ambulatory environment. And that's a necessary and viable business model going forward, because that's where care will increasingly be delivered and increasingly in the home. And so I think, if we want to have an innovative, technologically sophisticated health system that's affordable and drive care to lower cost settings, we should embrace, the ability to manage and combine capacity across the continuum of care. If you sit around with a bunch of hospital CEOs, and ask them what's the cost item that's going up the fastest, apart from specialty pharmaceuticals, it's going to be the subsidy they're providing to their employed physicians,
Right.
which is in the order of 100 to 200 to 300,000 per doctor in some cases, when you talk about specialists. So the economic pressures of private practice have brought more and more physicians, willingly into the fold, either of large health systems or in the case of Optum and other actors, into health insurers.
I think the cost goes up faster in a fragmented system. And the idea that that we are going to be relying on sophisticated information technology tools and artificial intelligence and telehealth and all the rest of this stuff, those are instrumentalities that we won't be able to fully realize as a society unless the entities that deploy them have a sufficient base of expertise and capital to push them out. So I think that's one big thing that gets lost. I mean, you freeze the health system where it is, and you don't grow the capabilities that could dramatically lower cost and improve the quality at the same time.
Look, every other industry, consolidation and integration has led to better, faster, cheaper. So, there is legitimate pushback that we haven't done that yet. We haven't delivered better, faster, cheaper, as evidenced by some of these price studies. But that doesn't mean that there isn't an inherent value to organized, integrated systems of care held to account with an appropriate scorecard of performance and behavior. And that's really what we're urging for, is not to shut the whole game down, but to mold the game to be accountable for the communities they serve.
And let's have a conversation about the rules, about what appropriate conduct is that actually improves people's health. And let's talk about, in concrete fashion, how patients are going to benefit. And let's make sure those benefits get delivered. So I think that's the conversation we ought to be having. It isn't about control. It's about what it is that we encourage and expect health systems to do with all these resources.